Hey everybody, welcome to my back porch. It's a nice night, so I'm doing my video to you out here. I know you've had a chance in class to look, thank you, at vision, and what I want to do in this video is just summarize some major concepts. So I know that you, without even talking to Donna, you probably are a little anxious about some of the topics you were looking at, and if you really understand what you need to know. So this video will kind of give you an overview. I'll touch on a few key topics. We'll do a little bit more with vision in class, but this should help a lot. Okay, so what I want to do is just talk about some of the basic structures of the eye, and then we'll focus on some aspects of how the eye actually works. What you should understand at this point is there are three layers to the eye. The fibrous tunic, which is going to be, oops, I don't know why I moved, which is going to be the sclera, and where is it? The cornea. So that's the fibrous tunic. If we look at the vascular tunic, we're talking about the choroid layer, we're talking about the ciliary body, and the iris. And then the retina, of course, the inner layer, just for consistency, let me make it a different color. The retina is the innermost layer of the eye, and that's what we associate with where you find the photoreceptors. Now, the eye itself, it does do vision, and that's what we associate with the eye, of course. But all the parts here have a purpose. And what you should be able to do for the parts that are underlined here is discuss what they are and why they're there, or what's the significance of those parts. Let's go through them. I'm going to go around pretty quickly here, so if you need to go back and look at these, you can. The ciliary body suspends the lens. The tension on the ciliary body controls how flat or how round the lens is. The lens has to be really round to focus on objects that are up close, and it has to be relatively flat when we're focusing on things far away. The cornea is the clear part of the fibrous tunic. A significant part about the cornea is you have a lot of light refraction here. When someone has laser surgery, that is what they're actually fixing. They can't fix the lens to fix someone's for laser surgery, but they can fix or reshape the cornea. So whenever you hear of someone having laser surgery, it's actually to reshape the cornea so it bends the lens in just the right way, bends the light in just the right way. When it reaches the lens, it's going to end up focused correctly. Okay, the iris and the pupil, of course the pupil is going to be the hole that light passes through. It's controlled by parasympathetic and sympathetic impulses. So parasympathetic tends to have one influence, sympathetic the other, and you should know which one is which by now. The iris is going to be the colored part of the eye, and that actually controls the arrangement of muscles, actually controls the opening and closing of the pupil. Too much light, if it enters the eye, is blinding. Too little is not enough to stimulate the photoreceptors. So the pupil has to be changed in size by the iris. There's an anterior cavity here, this space between the cornea and the opening of the pupil. So it's an aqueous layer. It protects the front of the eye. We won't get much into the details of this. It does bend light, but only ever so slightly, and we're not going to worry about too much here. The lens is a crystalline protein lens, and it does change as we age, but if the lens is focused correctly, if it is in just the right shape, it allows us to bend light so that it lands directly and correctly on the retina. The optic disc, or the blind spot, is the region of the eye where there are no photoreceptors, and if by chance you were to focus light on that spot, you wouldn't perceive anything. Now, the reason we don't walk around every day and we're seeing blind spots when we look around is that our eyes compensate. It's unlikely that you can focus, actually it's probably impossible, that you can focus light directly on both optic discs at the same time. So if you happen to focus it on one optic disc and it would be blind, the other eye and the brain kind of fill in the gap so you don't even perceive the light is not correctly positioned on the retina. The optic nerve, of course, is going to be transmitting all the nerve signals eventually to the optic cranial nerve, to the optic nerve. The fovea centralis and the macula The fovea centralis is going to be where you have the highest concentration of cones. The macula is the region around that. So we do tend to focus, for our most direct, correct vision, focus things directly on the fovea so we get the most intense vision that we can, the most detailed vision. The retina, of course, is all this yellow. It's where you have the photoreceptors, the rods and the cones. The choroid layer, again, is part of the vascular tunic, so it's going to have a lot of supporting blood vessels and other tissues that support the rest of the eye. And the sclera is a hard, tough covering, ligament-like in a way, that protects the eyeball and helps make sure it doesn't collapse on itself. Okay, we're going to do the rest of the slides a bit faster. So I want you to have the overview of some major functions. And I want to go. Okay, so just a few things to point out here. This is diabetic retinopathy. This is a normal retina. Here's what happens if somebody experiences complications with diabetes. You have these microvascular changes in the eye, which damages the retina. So if you don't have the adequate blood supply, the retina breaks down. We can treat this disease, but we can't cure it. And smokers are a lot more likely to have diabetic retinopathy than non-smokers. This is just how it looks if somebody has normal vision, and this is what happens to somebody. This is what they actually see if somebody has retinopathy. One thing that, if you've done the eye dissection in lab, and if not, it's coming soon, that you might be surprised to find in the eye is that you have this vitreous humor. You have this jelly-like substance that exists between the lens and the retina. And so you see here in this, you don't see it well here, the anterior segment we were talking about before has the aqueous humor. The posterior segment has the vitreous humor, this jelly-like substance. It does help maintain the intraocular pressure, and it seems a little odd that light has to shine through this to reach the retina, but it does, usually successfully. Though what you tend to see happen in some people, especially the elderly, is they'll develop what they call vitreal floaters. They'll get these, it's an immune reaction, they'll get kind of these little clumps in the vitreous humor, and they will see sort of spots or kind of flecks in their vision. It's not dangerous, it's nothing to be too concerned about, but as the vitreal humor changes a little bit and it gets a little more compressed and shrinks a little bit, these clumps are more likely to form. So you may hear of that if you work with the elderly, that they're seeing these objects kind of floating in front of their eyes, and you see down here what it looks like in the kind of these specks. So as light shines through it, you'll see kind of shadows, little teeny shadows from time to time. Okay, this is just showing you the optic disc again. Let me get out of the way. Let me get out of the way. So here you see, once again, there are no rods and cones because we have to have the entrance of blood vessels and the entrance, or the exit rather, here of the nerve tissue. So that's the one spot we're not going to find any kind of photoreceptors. Here you see, again, it's kind of light here because there is nothing to absorb the light, so it's sort of shiny. So this is the view that the doctor sees when he's looking in your eye at the eye doctor. He's looking for, there it goes. You're looking for healthy blood vessels. You're looking for, no splotches at all. You're looking for a healthy macula, and again, the fovea centralis is going to be in the middle of this. One condition that we associate with age is the degeneration of the macula. We have that region where we have lots of cones, and the fovea centralis even more and more cones. But for some people, they develop AMD, age-related macular degeneration. And this slide shows you if somebody this is the normal vision, and again, you're shining the light directly on the macula. If somebody loses their macula because of degeneration, this is the view they see. In the middle of their view, they see nothing because the macula is gone, and kind of to the sides of their view, they can see slight objects, but not a lot of detail, because the further you get away from your macula and your fovea, the less detailed your vision is. We won't get into all the causes of AMD. Smoking is a complicating factor. Other conditions like diabetes can make it worse, but it's one of the more common causes vision problems when someone ages, AMD. So how do we form images at all? And again, this is where people can get a little upset trying to understand how vision works. I try to boil it down to the most simple concepts here. For us to be able to see something, we have to do several different things. We have to refract light. We have to bend light so that light waves are coming to our retina right at the same place, and they're going to therefore be focusable. So refraction is the bending of light rays. So they bend mainly through the cornea and also through the lens. And if everything goes well, all the images, all the points of light, if you will, are going to line up on the retina at the same point at the same time, and therefore we can focus that. The other thing we have to do, which goes along with refraction, is accommodation. You have to bend light harder for things that are up close. If you have your finger off in a distance and you bring it closer and closer to you, at some point the tip of your finger will get a little bit out of focus. If you're older, it will get out of focus, pretty far out. The younger you are, the closer you can get to your eye and still keep it in focus. We joke that when people get older, their arms get longer because they will read things out here like this, trying to go, okay, well, the reason is when the older you get, the less you can bend light. What happens is most people, mid-40s and beyond, develop presbyopia. Their lens continues to add crystal to it, crystal proteins rather, and that tends to make the lens less elastic as we get older. When you are young, you can bend light really hard, really up close. You can accommodate light. The older you get, the lens can't get as round and therefore can't get into a shape that makes it focusable, so you have to wear reading glasses. And the other area we have to handle to really get an image formed properly is to regulate light levels. And again, that's the purpose of the iris and the pupil. You see here an undilated pupil versus a dilated one. Dilated means that we're going to allow a lot of light to enter, and when you have that, when the pupil is large, as you see here, a lot of light can enter and stimulate lots of photoreceptors. That's why when we are in the dark, we want to have our pupils dilated, letting as much light as possible. And when we are in bright light, we tend to reduce the amount of light coming in because it fires too many photoreceptors and we can't see. Just how we look at vision abnormalities. I don't know why I keep moving around tonight. This is an emmetropic eye. The lines here are showing you light waves. And notice how they're coming through the cornea. They're not showing you very much bending here, unfortunately. They show you the lens and how all of these light rays are going to be actually at the exact spot, the focal plane of focus for the eye. Because they're all landing exactly where the retina is, then you get to see just fine. Your vision's great. Okay, if you're myopic, okay, then the effect of the eye is it's too long. The eyeball is actually too long. So when the waves come in, well, here we go. Waves come in, they go through the cornea, they go through, again, the aqueous humor, pass through the lens, and they're all in focus right there. Problem is, the retina is over here. So notice how they're scattered when they're hitting the retina. So that's going to give you a blurred vision. How do we handle that? We give someone a prescription for glasses, and this might be a minus lens. That is, you'll see in the prescription minus 1.5 or minus 2 or minus 0.5. Okay, the minus indicates myopia, and so the concave lens is going to bend the light before it reaches. So this is someone's glasses. So it bends the light before it hits the cornea, passes through the lens, and then it's actually going to be in focus back here. Someone who's hyperopic is going to have the opposite situation. Their eyeball's too short, so light waves pass through. They pass through the cornea and the lens, and here's where the retina is. So notice again, the lines are not together. They're actually a little bit spread apart. So once again, they're going to have a blurry vision. A convex lens, a plus lens, like a plus 1.5, is going to bend the light in a way so that when it passes through the cornea and the lens, it actually will be in focus again. So if you see a point plus 1.5, that is hyperopia. That's farsighted. They can see far away, but they can't see up close. Someone's myopic is nearsighted. They can see up close, but they can't see far away. And once again, if someone is going to have laser surgery, it does not fix the lens. It fixes the cornea. So if you have laser surgery, and let's say, like I had mine when I was 35, and they said, hey, this will be great, you will probably never need glasses for distance vision, but we're just letting you know when you get into your late 40s or 50s, you're probably going to need reading glasses. Most people do. And true enough, you know, I went a long time, but when I got to in my advanced age, then I do need reading glasses because once again, the lens is going to change over time. The laser surgery, you know, doesn't fix your lens. It only fixes the cornea. Okay, we're not quite there, almost. Okay, so just a few abnormalities I want to mention. Astigmatism. Many people have astigmatism. It means the cornea or lens is not perfectly shaped. It has some irregular curves to it, and that's why you may have certain parts of your vision that are blurry and certain parts that are fine. And so many times astigmatism is easy to correct if it's not too pronounced. If you have really bad astigmatism and your cornea is shaped like a wave, they may have a very difficult time doing a laser surgery on you because your cornea is too irregularly shaped. Cataracts is actually one of the leading causes of blindness, and it's when you appear to get a film over your eye. The leading cause of this actually is UV exposure, but people who have diabetes, who are going through radiation, even when someone's older, in their 70s, it's pretty common to have cataracts. And it's because the protein lens denatures. It doesn't maintain the same integrity, and it becomes cloudy, and light can't pass through it. And many times they can do surgery for people with cataracts, and it's quite successful usually. But it's one of the leading causes of blindness if it's not corrected. So if someone's having an eye exam, what are they looking for? They're looking for issues with the cornea. If someone has infections or ulcerations, they're looking for retinal vessel occlusion. They're seeing if all the vessels of the retina are actually seem to be functioning, seem to be open. It sounds a little bizarre, but when you look in someone's eye, you're actually looking directly at the blood vessels in the back of their eye, and that's why it appears red. When someone has photography and they have red eye, what you're actually doing is you're seeing the reflection of the light off the redness of their blood vessels. It's okay, it's normal, but that's why you get that red eye appearance, because light went in there and kind of shone all the blood vessels. And apparently there's a fire or something near me. I'm going to keep talking. Retinitis pigmentosa is a rare condition that can actually damage the retina. It damages several parts of the retina. We won't get into the details of it. It tends to be a pretty unusual condition, but you do see it in kids sometimes. Retinal detachment. Usually trauma causes, there's actually a couple of layers of the retina. There's a neural layer, and there's where the photoreceptors are, and they can attach. But one story that came out last year I thought was kind of cool was a Facebook diagnosis of Coats disease. A woman posted a picture of her daughter, and this is her, on Facebook. And someone saw this, and they said, you need to get that girl checked. Mom thought it was just kind of a weird trick of the light while the girl's eye appeared to be somewhat yellow, but actually it's an indication of Coats disease, where many people are going to have red eye. When you have a yellow eye, that's because of extra cholesterol deposits in the eye, and that causes issues with eventually the retina. Eventually it causes the retina to not function anymore. This girl did lose vision in her left eye, but it was, but it really was a good thing that a nurse saw this, because she alerted the mom, and mom got treatment, and then the girl didn't lose vision in both eyes because it would progress. So it was a Facebook diagnosis of a potential blinding disease. What I don't want you to stress about this is how we actually see, because it's a pretty complicated process and gets into some physics. Essentially, when we process light, we're processing it either with rods or cones. There's 3 different kinds of cones. Excuse me. And depending upon which of those cones are activated by which wavelengths of light, we turn on or turn off rather certain kinds of signals that our brain interprets as, okay, I've received this signal or that signal from the photoreceptors. Again, this is a little bizarre down here. Light provides a stimulus to inhibit the firing of action potentials, because normally when we are basically exposed to the darkness is when our action potentials are firing, basically saying don't do anything, don't do anything, don't do anything. Light shuts off those signals, so then we do have signals that are coming through. So it kind of works opposite. Light doesn't stimulate action potentials, it actually inhibits the firing of action potentials. But again, don't stress about this. Do understand the difference between rods and cones though. Rods are stimulated under low levels of light and give us our black and white vision. So if you're driving along at night and you look out to the sides of the road, you're not seeing colorful trees and colorful cars. You're seeing, shapes, broad shapes. You don't see yellows and you don't see pinks. You see shades. Cones require a lot of light to stimulate them. So that's why we associate this with color vision and high light vision, because it requires much more light to make them active than rods. When someone has color blindness, then they have some deficiency of either their blue, green, or red cones. So there's different kinds. This is sort of a cute way of seeing this, but you see if somebody has a different kind of color blindness, what they're getting in terms of their vision. You see this view. Oops. You see this view here. That notice how reds and greens all kind of look the same. You're not getting a lot of, again, look at her color here and back there, and somebody who has red-green color blindness, you're seeing almost the same thing. They can tell slight differences in intensity, but that's a pretty typical to not be able to distinguish colors very well. Color blindness, of course, is more common in males. It's a sex-linked condition, but women can be colorblind too, but it's more common in males. Visual pathway. I just want to point out here, as you see this colors in this chart, that the left visual field from both eyes travels to the right side and mainly processed in the occipital lobe of the right hemisphere. The right visual field of both is going to be processed mostly in the occipital lobe of the left hemisphere. At the optic chiasma, which means cross, you have the nerve waves passing. Why that happens, we're not totally sure. But it brings into this question of how do we see? And we do know from brain injury patients, vision is a pretty complicated thing. As you see here, this person's processing color, depth, form, and motion all at the same time. As you're seeing down here on the chart, you're seeing that you process all of those things in different parts of the brain. So somebody could have a part of their brain that's damaged to where they don't process color, but they do process depth and form and motion. We know also the brain uses lots of tricks. And you've probably experienced that if you've looked at a lot of optical illusions. The brain can be fooled into thinking things because the brain uses tricks. I'll just give you one as an example. Most of the time, the brain interprets light as it should come from above. We have this big thing called the sun, or we have lights in our houses, and we're used to light coming from a certain direction. Look how different something looks if you are having the light coming up from the bottom and lights things from below. The brain has a difficult time sometimes understanding that because it's not it's not one of the brain's shortcut tricks for vision. As we wrap up, I want to show you this. Based upon the physics and the optics of the eye, when light passes through the cornea and the aqueous humor and the lens and the vitreous humor and it reaches the retina, it actually, the image based on the physics, is coming into our eye upside down and backwards. How does the brain turn that around? We don't know. But that, again, there's a lot about vision that we don't quite understand. But as I mentioned, sometimes we're really intrigued with optical illusions and things that kind of fool the brain. If I said, if you wanted to do this, if I said pause the video and find the hidden tiger and you would start looking, because you have now in your brain what the hidden tiger looks like. And it's not this thing, because this thing is not hidden. But if I said find the hidden tiger and you really want to find it, take a minute, pause the video and see if you can see it. And if not, I'll show you where it is in 3, 2, 1. The hidden tiger, I can find it, is right here. Here is the hidden tiger written in the stripes. So there again, your brain was processing what a tiger looked like and not looking for the words. A little sneaky, I know. Okay, we'll do one video also on hearing, so in balance, so you're clear about those. But again, I don't want you to stress about all the details of vision, because it gets pretty complicated. But do know the parts of the eye, and do understand the diseases that we presented in this video. Thank you very much.